surgeon wants from the radiologist. My outline of the talk will be predominantly liver segments based on CT, how we can identify the liver segments, then how we do liver volumetry, how we annotate the liver, then few anatomical variations, and how to apply this knowledge in real cases. Just a minute. So moving forward, I will first explain segments just on the pictorial depiction. So liver is segmented in 8 lobes, and this is liver is the functional. Each lobe is functional unit of liver. So Conrad has segmented it into 8 particular segments, and then this is done by mainly left hepatic vein, middle hepatic vein, and right hepatic vein. If we just come from the left lobe, then here is the left lateral section, and this is left medial section. In between is the IVC, and to the right of IVC, this is the right medial lobe, and this is right lateral lobe. Moving forward, I will just show this on CT axial section, how we can identify the liver segments. On the CT axial section, what we can see here is the left hepatic vein. This is the middle hepatic vein, and this is the right hepatic vein. If we draw imaginary line on this hepatic veins like this is the middle hepatic vein, and this is right hepatic vein. Then the segment which is seen on this particular section is segment 2. When we are going down and we see portal vein, then this is segment 3. In bit again, I'm coming in superiorly, and this is the left hepatic vein, and this is the middle hepatic vein. In between the segment left hepatic vein and middle hepatic vein, this is segment 4A. And going down, once we start seeing the portal vein, it is segment 4B. So same way, in between the middle hepatic vein and right hepatic vein, it is segment 8, and inferiorly, it is segment 5. There is another landmark to identify the segment 5 is gallbladder fossa or gallbladder. And same way, adjacent to the segment 5 is segment 6 inferiorly, and going superiorly is segment 7 all the way. What is important in segmental resection or CT liver volumetry is identifying the hepatic veins properly. And the most important hepatic vein is middle hepatic vein. So starting from the IVC, this is the ostium of the middle hepatic vein. You can see clearly. This is segment 8. As I said, this is superiorly. Then moving down, it is the middle hepatic vein, and in the mid plane, there is a segment 8 vein which is going, and then this is segment 4A vein, and this is segment 4B vein, and this is segment 5. So actually segment 4B and segment 5 vein forms the middle hepatic vein. It is joined by segment 4A vein, and Further, it joins by segment 8, and this is another segmental vein which is draining segment 8, but it is in the midline plane, so it is not very important. But this particular vein, which is of good size, that is very important. Normally, when we do liver resection, it can be right lobe with MHV or without MHV, or left lobe with MHV and without MHV. So in that particular case, we need to know what are the segmental veins which are draining into the middle hepatic vein. So if it is in a case of recipient will not have MHV, donor will have MHV. So left lobe with MHV will be there with the donor. So in cases of recipient, they will have neo MHV, which is reconstructed, and this particular segment 8 vein will be reconstructed with the neo MHV. Same way, if we go down and see the segment 5 vein, that will also be reconstructed. So we need to know how are the segment 5 and segment 8 vein, what is the number, what is the diameter. So this is very important in case of CT volumetry and further roadmap for the volumetric assessment. So now, as we just saw, and the main plane of decision is right hepatic vein, middle hepatic vein, and left hepatic vein, as well as portal vein. Going down, what are the other things which we can identify the segments is, this is right kidney, which is adjoining the segment 6. So that is another landmark which we can use on ultrasound for identification of the segment. So up to inferiorly, this is the segment 6, which is draining this segmental area. Now we will go forward with the where we use this CT imaging techniques for CT volumetry. What is the technique we use is the multi-detector CT angiography with 100 to 120 ml of contrast will be injected, that is with the flow rate of 5 ml per second, and reconstructed 0.6 millimeter sections will be acquired. Phases will be plain first, because we identify the liver attenuation index on this. Then next will be early arterial phase, which will be taken at 16 to 20 seconds, then late arterial at 30 seconds, and portal phase at 50 seconds, and hepatic venous phase, that is at 80 seconds. What is the importance of CT volumetry? It is not just for the transplant surgeries, it is also for the hepatobiliary surgeries, where it can be HCC, it can be cholangiocarcinoma, or it can be just benign tumor which are larger in size and they need resection. So in those cases also, CT volumetry is used. Then the treatment response. How is the treatment response? So volume reduction in the disease can be seen. What are the types of liver resection? So it is left hepatectomy, which is commonly used. Then with or without segment 1, that is the caudate lobe. Then extended right or right trisectionectomy, that is addition to the right, there can be additional segment can be taken, that is the segment 4, A and B. Then left hepatectomy, that is left lobe, entire left lobe. Then extended left lobe with segment 5 and 8. Then there can be only sectionectomy, as we saw right posterior section, that is segment 5 and the right posterior is segment 6 and 7, right anterior is segment 5 and 8, and left medial sectionectomy is segment 4, that is 4A and 4B, and left lateral sectionectomy is segment 2 and 3. But in cases of transplant, how these are slightly different from the routine resection is left lateral segmentectomy or hepatectomy is done for children because they need a small graft volume. Left lobectomy, that is segment 2, 3, 4 segments with harvested MHV will be taken. But nowadays, normally they do right hepatectomy with without MHV. That will be the routine practice, and there will be neo MHV or harvested MHV in that case. Then right posterior sectionectomy graft, that is only segment 5, segment 7 and 6 will be taken, but it is very rarely used. And then left extended graft, that is left lobe with left right anterior section will be taken from the, so that is also rarely done. So if we are doing CT volumetry, prior to that, we need to know what is the status of the liver, background liver. That is the liver attenuation index. We need to count, and we get that is depend upon the difference between the mean hepatic and splenic attenuation. It has sensitivity of 88 to 95% and specificity of 90 to 99%. And LAI more than 5 will be taken. This is mainly in case of transplant. We will just see how hepatobiliary surgeries are done, and on in the hepatobiliary surgeries what is used. Then MR fat fraction can be performed, that is with ideal IQ, and to look for any fibrosis, MR elastography is performed. So this is in case of transplant. But if we are doing hepatobiliary surgery and we are going for the CT volumetry, first we need to know how is the liver status, that is for the fact whether background liver is cirrhotic, that we need to identify. Then for what are the volumetry criteria? Because just doing volume doesn't give you any benefit. You need to know the volumes criteria for graft recipient body weight ratio. That is the graft volume divided by body weight of the recipient. In the adult, it should be more than 0.8, and in children, it should be more than 0.1. This is like a future, how in the donor future liver remnant is there. In graft, it is future remnant will be predicted based on graft recipient body weight ratio. So that should be more than 0.8. Remnant volume should be more than more than 30%. And if patient has recently been on weight reduction program, FLR should be more than 35%. Because if these things are not followed, patient can get into trouble. In small for volume cases can happen. These are other for the CT volumetry. If we are doing it for hepatobiliary surgeries, then the donor volume means not the donor, the remnant liver should be more than 30% in case of normal patient having normal liver, not having any fatty liver. If there is a mild fatty, moderate fatty liver, then FLR should be 30 to 40%. And in cases of cirrhosis or chronic liver disease, it should be more than 40%. Now we will see how we can do the volumetric assessment by the manual way. So what we take here is the hepatic venous phase of CT axial section, then contour the liver from its outer margin, exclude IVC, exclude portal vein and this visceral fat as well as gallbladder. That will not be taken into account in these markings. And there are automatic method, there are semi-automatic and manual method. So manual method, these are vendor specific. We use a GE machine, a GE console, and on that it will be, once we manually contour the liver, it will give us the summation of the volume, and these type of images will be provided by the software. this is a manual method. We contour the entire liver, exclude the portal vein and IVC as well as gallbladder. So once we get these, then our role comes whether we need a middle hepatic with including middle hepatic vein or excluding middle hepatic vein, that we need to understand what is our requirement. So this is, I will just explain how we do it. This is a total, in this particular case, total liver volume is 1440 centimeters square or cc, and so we have deducted around 13% from this total volume, as these are, that 13% is of these hepatic venous, and the remaining portal venous blood volume is deducted from that, and this will give the actual predicted volume for the graft. So this is the total liver volume minus 13%, and this comes 1272. Then the right lobe without MHV. So this is the cut margin, and this is taken from the GB fossa. First we mark the GB fossa and then go along the middle hepatic vein, and that gives you the right lobe without MHV. Here in case of this it is 865, and as I said, graft GRWR is taken into account in respect to recipient's weight. So this is the 865 divided by recipient's weight into 10 is the factor which is they have taken. So 865 divided by 750, that is the GRWR expected, that is 1.15. So same way, what will be the remnant liver volume? That is the remaining volume with the donor, that is this particular part, and that is 407, and future liver remnant will be remaining liver volume or the remnant volume divided by total liver volume. So that came up to 13.1%. So this way we calculate the FLR as well as GRWR and total liver volume. So this was a case of transplant. So we included we excluded portal vein, IVC. But in case if you are doing for the other hepatic surgeries, you don't have to exclude the portal vein and IVC, because what you are going to do, you can just take according to that and just deduct 13 to 15% of the volume. If we are doing automatic method, we have to just include these sections or the venous space into the software, and that will give you exact how is the total volume, and it will also give you if you feed that right lobe with MHV or without MHV, it will give you the volume directly. So these are AI generated methods. These are slightly, the softwares are costly, so we go with the manual method. Then comes the how we translate the planes. So if it is a right posterior segment graft, so graft will be this particular area, and this is the right hepatic vein. As I said, how the hepatic veins are formed, that is very important. You can see here these segmental veins, like segment 7 vein. These are the segment 7 veins, and then this is segment 6 vein, and part of that is segment 5 vein that forms the right hepatic vein, and this particular area is the posterior segmental graft, and this will stay with the donor. And if it is a HVB surgery and you are going to do this posterior sectionectomy, you will remove this particular area, and for because of the tumor or some other reason, then this will be the future liver remnant. Now this is a right lobe without MHV graft. So this is a line of demarcation. This is the gallbladder fossa line, and we go above up to the confluence of, this is segment 5 and this is segment 4. This is most important because if you can't identify the segmental veins, you can't resect the margins. So here is the segment 4 vein. This is segment 5 and another segment 5 vein, and the gallbladder fossa is the important, because if in cases of borderline FLR, you need a correct margin, because even we resect on the radiology, this can be slight 10% plus minus. So you need to identify particular exact plane for that. Moving forward with the left lateral section, same liver. Now this graft is for the child and we just want the left lateral section. So the plane of resection will be in the fissure for ligamentum teres, and the area which is remaining on the left side, that is the segment 2 and segment 3. So how this left hepatic vein is formed? This is the segment 2. This is part of segment 2 and segment 3, and this is segment 3. So these are the hepatic venous tributaries we need to understand, because sometimes when there is a monosegmentectomy, if the GRWR is more and they want to take only monosegment, that is segment 2, then what we need to do is resect the segment 3, and we need to give the volume just of segment 2, which can be, and check for the GRWR. This is another case where left lobe with MHV need to be taken. Most of the grafts in the left lobe are left lobe with MHV, because it is difficult to do anastomosis of the tributaries of segment 4A. So they always take left lobe with MHV for transplant cases. But if this is a case of hepatobiliary surgery and we want to just do the resection with left lobe without MHV, that can be performed. So this is another case where the left lobe with MHV resection, left lobe without MHV was taken on this side, and this is the MHV, and this is the GB fossa marking, and this is the final volume. Now we will just go through the arterial anatomy variations, because it is important to know the arterial, portal venous and venous anatomy, as well as biliary drainage, to do the resection, or whether we can go forward with the resection for that particular process. This is the Michael classification. These are multiple variational anatomies. We will just go through few important anatomical variations. Hepatic arterial anatomy, what we need to see in this particular cases is check for any ostial narrowing, any accessory or replaced arteries, then the diameter and length of the vessels, origin of segment 4 artery, which is very important based on which lobe they are donating, or even for HPB surgeries, whether there is any crossover. Abdominal vasculature, that is to look for any aneurysm, fibromuscular dysplasias, or MALs. So this is a conventional anatomy where the celiac artery divides into gastroduodenal artery, hepatic artery proper, and then hepatic artery proper further divides into left hepatic artery and right hepatic artery. Now what we are looking for in these surgical cases is how is the anatomy. So segment 4 artery is arising from the left hepatic artery. What we see is the length of left hepatic artery, because at least 5 to 6 millimeter of length they need to do the anastomosis. And how is the diameter of the vessel? So that is also important. More than 1.5 millimeter diameter will be good. Otherwise, there can be chances of thrombosis. So they can go for some other donor, or if it is a difficult anatomy, or then they can have different type of resections. So this is right hepatic artery, where this is the anterior branch and this is the posterior branch. Branching pattern is important. This is mainly in case of donor setting, donor and transplant setting, because here is the extrahepatic branching, and this is the intraparenchymal branching. Intraparenchymal branching, they can't divide those vessels, so they need some extra hepatic length for dividing the vessel and doing grafting. This is another case, another variation where segment 4 artery arises from the right hepatic artery. Then the replaced left hepatic artery, and segment 4 artery is arising from the left hepatic artery. So replaced left is from the left gastric, and then common hepatic giving gastroduodenal artery and the right hepatic artery. And these are the anterior and posterior branches. Here is a case where there is a replaced left hepatic artery from the left gastric artery. And what we need to understand is this segment 4 artery origin, that is from here. So if this patient is undergoing transplant for right lobe of liver, it is difficult for getting extra hepatic length for the right lobe. Then comes the segment. This is another variation where this is the celiac trunk, gastroduodenal artery, and then the posterior right hepatic artery here, and then segment, all are different segmental arteries. This is segment 2 artery, and this is segment 4, and this is the anterior segment, and this segment 4 artery arises from the anterior segment. So if the patient is undergoing left lateral resection, it is difficult. Here is the case where there is a left hepatic artery which is replaced, then replaced right hepatic artery, and segment 4 artery arises from the common hepatic artery. Another segmental artery where the segment 4 artery arises from the right anterior hepatic artery. These are more important origin of the segment 4. Even if it is from the right, that is fine. Moving forward with the portal vein anatomy and its variations. This is the classic type A Nakamura variation of the portal vein, where the main portal vein divides into left portal vein and right portal vein, and the right portal vein further divides into right anterior and right posterior branches, and left portal vein has segmental branches, that is segment 2, segment 3, and segment 4. Here is the portal trifurcation. So if this is a case of transplant for the right lobe, there can be 2 portal vein anastomosis, and if it is for the left lobe, there will be single anastomosis. What we need to know, where is the segmental veins arising. So this is segment 4, and this is segment 2 and 3. And this is another segment 4 vein. We need to know what is the diameter of the portal vein as well as what is the length. So that will decide whether only single anastomosis is done or double anastomosis is done. Then sometimes accessory segmental veins arises from the main portal vein or the right portal vein or left portal vein. So here the accessory segment 6 vein first arises from the right portal vein, and then further there is right. These are like segmental veins, right posterior portal vein, which is supplying segment 7, and then this is the anterior, and then there is a overlap between the right and left lobe. This is a type C anatomy where first main portal vein gives branch to right posterior segment, then that is a posterior branch, then right anterior segment, that is anterior branch, then left portal vein, and these are the segment 4 vein and segment 2 and 3 vein. This is a type where there is intraparenchymal branching, as I said, in the artery, in the vein is also done. So this is a right posterior vein, and this is right anterior vein, which is directly arising from the left portal vein intraparenchymally. These are multiple segmental veins. There is no right and left portal vein. This is not amenable for transplant, but resection can be performed in this particular case. So moving forward with the hepatic venous anatomy and its variation. So as we saw the volumetric view, this is the left hepatic vein, this is middle hepatic vein, and this is the right hepatic vein. We saw the how we do the segmentation, and these are the segmental veins which are draining particular segments. So this is segment 3 and segment 2, and you can see this segment 2 and these are segment 3 veins, and this is visceral vein which is draining into the left hepatic vein. This is important when we are doing the resection. So whether it comes along the line of resection or we have to take the resection plane on the other side, that we need to decide. So this visceral vein also drains multiple segments. So like here, it is draining segment 2, then it is draining segment 3 as well as segment 4B. And this is middle hepatic vein where it is draining segment 4A. This is segment 8. This is segment 5 and this is segment 4. And the right hepatic vein is formed by multiple veins, tributaries, that is segment 7 tributaries, segment 6 tributary, and few segment 5 tributaries. What we need to know is the diameter of the vessel at the ostia, then the segmental vein, as I said, segment 8 and 5 in case of right lobe of liver. This is the middle hepatic vein and the left hepatic vein form the confluence, and that forms the common channel. So that we need to identify. This is another dominant right hepatic vein, and the common channel is here. The other thing is right inferior hepatic vein. There can be single right inferior hepatic vein, or there can be multiple right inferior hepatic vein. What we need to know is the distance between the RHV and IVC confluence and the right inferior hepatic vein, because if they are going to graft this vein on the IVC of recipient, then they need to know this particular distance, the number of accessory hepatic veins, and what is the diameter of accessory hepatic vein, whether it is dominant. If it is less than 2.5 millimeter, then it is not actually grafted. So what we saw is the conventional anatomy, then segmental hepatic veins draining directly into the IVC, common left hepatic vein and MHV channel, then the inferior hepatic vein, diameters of the vein at the ostia, and segment 5 and segment 8 vein, and the dominant MH vein. And this way, we just give the portal vein, hepatic vein, and artery uh, images. Moving forward with the biliary anatomy, as it is important for planning the resection. So Huang has classified it into the right and left, that is type A and type B classification based on the segmental, that is the right posterior sectoral duct draining into, whether it is draining into the right or whether it is draining into the left. So if we just see here, this right posterior sectoral duct drains into the right anterior sectoral duct. And so this is type A. Same way, if there is a separate right posterior and right anterior, then type B. 3, right posterior will drain into the left hepatic duct. 4, right posterior will drain into the common hepatic duct. And 5 is right posterior will drain into the cystic duct. Same way for left lobe. This classification depends on the segment 4 duct. So whether segment 4 duct is joining the left hepatic duct. If it is joining the right hepatic duct, this is most important because there is a crossover. When the resection plane, this will drain into the right hepatic duct. Then segment 4B, this segment 4 duct drains directly into the CHD. And these are other segmental ducts. And these are the variations. We will just see few of the variations where this is the routine right anterior sectoral duct and the right posterior sectoral duct joins together to form the right hepatic duct. And on the left hepatic duct, segment 4 duct drains into the left hepatic duct. Then here, this is the right posterior duct, which drains into the left hepatic duct. And this is right anterior duct. And this is segment 4 duct, which is in the left hepatic duct. So this is A3B1. So we identify these segmental ducts. This is this routine trifurcation, right posterior, anterior, and left duct. This is accessory right hepatic duct draining into the cystic duct. And this is the RHD, which is formed by right anterior as well as right posterior duct. So these are the variations. If we are doing cholecystectomy, this particular variation we need to know. So cystic duct stump length, according to that we can decide, and biliary leak can be prevented. Here is segment 2 and 3 duct, which joins together here, and this is the normal A1 anatomy. Then another cystohepatic duct. These are very important variations. Now, as we saw about the arterial anatomy as well as portal venous and venous anatomy and how to do the resection. But actually, in real practice, how we do this, how to use this in the real practice. So, this patient presented with the obstructive jaundice and diagnosed with the hilar cholangiocarcinoma. So, you can see here that this is the ill-defined heterogeneously delayed enhancing lesion in the hilum, which is causing dilatation of right as well as left duct. And on MRCP images, there is no communication of third duct. It is non-communicating. So this is a case of 55-year-old male with hilar cholangioma, and there was no vascular invasion on the left side, but there was involvement of the segment 4 duct. So this is a type 4 block was there. So plan was to do the PTBD with in the right anterior sectoral as well as right posterior and left hepatic duct, because these were non-communicating. And then for the liver resection with left lateral lobe and CT volumetry and assessment with FLR. But when we did the CT volumetry assessment, the total liver volume was 1340. Then the remnant volume, because it was involving segment 4 duct, segment 4A and B was not taken into account, and only segment 2 and 3 we were going to resect. So here is the only left lateral segment, and that future liver remnant for this particular case without any fatty liver or fibrosis or cirrhosis, it was 24%. But the required FLR was 30%. So planned for portal vein embolization. So in this particular case, portal vein embolization of right portal vein as well as segment 4 portal vein branch was decided, and decided to do again a CT volumetry study for FLR and for the left lateral resection. So after 1 month on performing portal vein embolization, these are the strict artifacts from the embolization material, and these are PTPD tubes. There was a hypertrophy in the left lateral segment as portal vein embolization of right portal vein as well as segment 4B vein was performed. So here is the pre-embolization and post-embolization scenario, where there was on pre-embolization FLR was only 24% and post-embolization FLR was 31.7%. So because of portal embolization, FLR is increased, and we have decided to do further resection for this particular case. And the resection will be right lobe with extended hepatectomy, or that is the trisectrectomy, that is right lobe with segment 4A and 4B. Here is another case, 60-year-old male patient with HCC liver, elevated AP, and this is his CT, portal venous phase. This is the hepatic venous phase, and this is a proven HCC. So here, as you can see, this is the hypo-enhancing lesion in the segment. As now you see, you can identify the segments. This is the left hepatic vein here, and this will be the segment 2, and this is segment 4A. So it is in between the left hepatic vein and middle hepatic vein. You can see the streak of opacification here. So this is between the left hepatic vein and the middle hepatic vein, and this is the lesion involving the segment left hepatic vein as well as middle hepatic vein. You can see this is the caudate lobe. So the points here is, what is the vascular involvement? So there is vascular involvement. Portal vein and portal vein is partly occluded. Then hepatic venous involvement is there, and this is not a case of cholangiocarcinoma. This is a HCC. So ductal involvement is not, we are not considering in this particular case. So can we do liver transplant in this particular case? This is, our case is single tumor size of more than 11 millimeter, and invasion of middle hepatic vein as well as LHV. So these are the criteria which we see on, that is the we follow, that is Milan criteria. most commonly eligible criteria for the liver transplant among the patients with HCC. So our case is more than 11, single lesion with less than 5. So this is not under Milan, and no evidence of extrahepatic metastasis or vascular invasion. We have invasion of the middle hepatic vein as well as LHV. Even the expanded criteria, that is the UCSF, is not, it is not coming under this particular criteria. Total, that is the single lesion less than 6.5 centimeter. So we plan for the resection. So what are the other ways to put it into the Milan? That is downstage the disease to do TACE, TARE, or microwave embolization, radiofrequency ablation. If it is feasible, in this particular case, it was not. Then the liver, living donor liver transplant, but this was not for that, as well as DDLT. So tumor volume, the total liver volume was taken. That was 2403. Then the remnant volume, that is the right lobe without MHV, that is 987. And the tumor volume was 450 cc. So future liver remnant was 41%. As there was a background HCC, background chronic liver parenchymal early disease, this particular FLR was enough for this particular case. But now, this is another case of HCC where the entire liver was 3572 cc and the left lobe with MHV was only 856 cc. So the future liver remnant of this particular case is only 23%. So this is inadequate for this particular case. So we can apply this into our routine cases. This is a borrowed case where there was a HCC in the segment 8 and part of segment 7 with invasion of the right hepatic vein. So what they have decided is simultaneous portal vein embolization and TACE for segment 7/8 lesion. So while getting the future liver remnant to cease the process of the disease of HCC, they decided to do portal vein embolization as well as TACE. And we can see after portal vein embolization, this lesion is decreased in size, and because of the portal vein embolization, right lobe is slightly decreased in size and the left lobe is hypertrophied. But they are not done with segment 4 vein embolization. So the entire left lobe with segment 4A and 4B, there is a hypertrophy. This is another scenario where you can actually use the volumetric assessment. So this is a case of chronic liver disease prior to transplant. We can predict the splenic steel prior to the transplant. So this was the liver volume of chronic liver disease with gross ascites 799, and this is the splenic volume which was grossly enlarged in size, that was 2784. So as well as there are few other things where the hepatic artery diameter and the splenic artery diameter, the difference and the dilatation of the splenic artery. In this particular case, there were few few aneurysms in the splenic artery. So these are few predictors of splenic steel syndrome after the transplant. So splenic volume more than 830 to 850. In our case, it was huge, 2784. Then spleen to liver volume ratio, that when I calculated, it was 3.5, that is more than 0.5. Then the liver volume. This we do that after the transplant if there is a suspicion of splenic steel syndrome. Then liver volume estimation is also done. Then other criteria are splenic artery diameter, more than 4 millimeter, in this case particularly 8.1 millimeter. Arterial diameter ratio, that is the splenic artery to hepatic artery diameter ratio of more than 1.5, which is a key indicator of potential steal. Then the artery diameter difference, that should be more, at least more than 6 millimeter. And portal Doppler plays important role in the post transplant setting. So these are few predictors for we can decide whether after the transplant surgery we can go for the portal vein splenic artery embolization in these particular cases to decrease the flow and increase the flow to the liver, so to prevent the splenic steal. So with this, what we need to check for the CT volumetry is how is the background liver, even in the case of donor setting or HPV surgeries. So whether it is fatty, whether it is fibrotic or cirrhotic. Then if it is a case of any tumor, PET-CT for extrahepatic disease, because with extrahepatic disease, we will not go forward with the CT volumetry. Then the vascular invasion, that is a deciding factor for plane of resection. So for all this, you need to know the arterial as well as means vascular anatomy as well as bile duct anatomy very clearly. And my take home message will be clear understanding of biliary anatomy, vasculature, and segmental anatomy is required to get a good surgical roadmap and validate the CT volumetry. And on preoperative imaging, it helps in reducing intraoperative surprises and morbidity in the recipient as well as any HPV surgery patient. These are my acknowledgements and thank you for patient listening.
Thank you, Gayatri, for that amazing talk. It was really informative and you took it at a good pace so everyone could follow you what you were saying. There are a couple of questions in the Q&A. Can you pick and choose the ones that you want to answer them in the Q&A
Yes.
section? Thank you.
So someone has asked 13% is taken as a standard correction for all the patients. Not like that. Uh, According to the diameter of veins, sometimes patients have very dilated veins, that is the hepatic veins or the portal veins. Sometimes studies are dehydrated, that patient without hydration they come and do the CT volumetry. So in those cases we take 10% as a standard correction factor. Otherwise, if there is a good diameter that is more than 7 millimeter, then 13%. And even sometimes if it is the diameter of hepatic veins is more than 8 millimeter, I even take 14% of the correction. So they are saying, can I repeat the volumetric technique as such? Then it is whatever software you have, or if it is a Siemens or G machine, what you are using, then you have to actually identify, means first contour the entire liver on the console, and then on console itself it will give the volumetric view. So that much only what you need to understand. And then after that, the plane of resection is very important. What is the cutoff diameter you can take for portal vein, hepatic vein, and splenic vein on CT? This is for, there is if you say for portal vein, there is no cutoff diameter as such. I don't know for which they are saying this cutoff diameters are used.
It's okay, Gayatri. Can you just go through the Q&A and not the chat? Uh,
Okay.
Q&A section, yeah. And there are
Mhm.
12 questions in it, I think.
Okay. I'm not able to see the Q&A.
Okay, I'll just put them across.
Ah,
The first question is, what is congestion volume? Is there something that's called
I,
congestion
uh,
volume?
I don't know actually what is means there is nothing like congestion volume as such.
Okay, okay. The next is there anything that's like splenic artery steel?
Yeah, I told about that splenic artery still. So the difference between the hepatic artery and splenic artery diameters, their ratios, and the splenic volume, spleen whole volume, as well as liver volume, difference between those two, as I explained about it in predictors of splenic steel syndrome. In that, the same thing is post transplant, there will be splenic steel syndrome, and there we consider splenic volume, spleen to liver volume ratio, as well as the liver volume, and it can be detected from even Doppler, that hepatic artery resistive index of more than 0.80, and hepatic artery velocity, which has low peak systolic velocity, less than 35 centimeter per second, and the splenic artery velocity, it has high velocity. So these are few of the indicators of splenic steel syndrome, and clinically patient will have cholestasis. There will be obstructive jaundice also further. So from the clinical perspective, we will see these things.
Okay, thank you. The next question or a group of questions are with respect to the correction factors. What is the
So
correction factor?
I already said that is about I normally take 13% in the good diameter vessels. If it is like dehydrated scan, I take 11% correction factor. And if it is like more than 8 millimeter or 9 millimeter vessel diameter, then I take up to 14% of correction factor. So that is what we are when we are taking the graft volumes. Actually, in surgery, after surgery, they are correlating. So what I am taking, that is correlating with the graft volumes. So we go forward with this particular method.
The next question is, so the cutoff diameter is when to call them as dilated and when it is normal. And also, is there any cutoff for rejecting a donor or something like that?
Okay, so based on diameters, we don't reject the donors. The anatomical uh, position of the arteries, mainly the arteries, that is more important. If there are three arterial anastomosis, then they go for another donor. They will first see, because they want less number of anastomosis, less number of arterial anastomosis, less number of bile duct anastomosis. So even two portal veins, even three portal veins, they can do surgery. They don't reject based on portal veins, but mainly based on the hepatic arteries. And that, as I said, segment 4 artery origin, that is more important. If it is a left lateral segment, and segment 4 artery, if it is a left lobe, or segment 4 artery is arising from the right hepatic artery or right anterior hepatic artery, then that can be one of the reason for rejection, because you there will be more ischemic area in that particular case. Then the length of the hepatic artery and the position of common hepatic duct, whether it is anterior or posterior, that is also important. So length of right hepatic artery, they at least need 7 to 8 millimeter length of right hepatic artery.
The next question is types and how to decide about biliary anastomosis. Like,
Okay. So as I said, more than types, you need to describe the anatomy, and main deciding factor will be right posterior sectoral duct and the segment 4 duct. So if it is a right lobe graft, then even it is a type A1 anatomy, that is the right hepatic duct is formed by right anterior as well as right posterior sectoral duct. But you don't get the good length, that is at least 5 millimeter of length for anastomosis. Then that particular patient can have two ductal anastomosis. So it is very important, not just the type of anatomy, that if I say this is a type A1 anatomy and patient has to undergo two ductal anastomosis. So then it is important to describe that there is a short right hepatic duct. So that is more important, the length of the hepatic duct. Diameter as such will be variable, ranging from 2.5 to 4.5 millimeter in diameters. So that doesn't matter. It is the length of the right hepatic duct. Left hepatic duct, most of the time, it is easy to anastomose because left hepatic duct, mainly for the left lateral resection, it is performed. So even two anastomosis can be done, but the main deciding factor is right posterior sectoral duct where it is joining, and segment 4 duct. If just take a scenario where the segment 4 duct joins the right hepatic duct, then this is not amenable for the right lobe transplant. So that way we see it's not identifying the type, just it is the uh, length as well as any variational anatomy, that whether the quadrate lobe duct is draining or it is dominant, all those things we need to mention.
thank you. The last question is, in case of portal vein thrombosis, does the assessment change, like the diameter of internal, like diameter of hepatic veins, and is there any change, or everything is as it is?
Okay, in portal vein thrombosis, diameter is not important. It is where is the portal vein thrombosis. If you are considering it for the transplant, and this is a case of recipient who has already portal vein thrombosis, so where is the thrombosis, that is more important. That whether the portal vein thrombus is in the main portal vein, whether it is in the confluence of splenic and portal vein confluence, or superior mesenteric vein involvement is there. So they have to do first take out that thrombus while surgery. It is difficult, and if even the chronic thrombosis is there, then it is difficult to anastomose that portal vein. So we need to mention that sometimes there will be calcification in the portal vein in the chronic cases. So that is one important thing. So more than the diameter, it is the extent of the portal vein thrombosis is more important. And in cases of children in biliary atrasias, portal vein atrasias will be there. So that is very important in that particular case. So there, that diameter is important, where the coronary vein is draining, whether it is draining into the portal vein, it is draining into the splenic vein. That is important because they need to do the venoplasty. They put the graft as a portal vein because there will be portal vein atrasia, and that particular portal vein will not be useful for anastomosis per se. So for the graft purpose as well as for the length, in biliary atrasia cases, we need the diameter, whether it is, means it is not actually thrombus, but it is the atratic portal vein. So for the graft per se, we need the diameter of the portal vein.
Mm.
Anything?
Yeah, just the last question. This is a case scenario someone has posted. If segment
Huh.
4 arises from the right, then can the right lobe be resected with two anastomosis of right anterior and posterior ducts?
So segment 4 is from the,
Right hepatic vein, I think.
okay, segment 4 artery.
I have no clue. That's the question that they have put. I wish they had more clarified it further, but uh, yeah,
Okay, but if it is a segment 4 artery arises from the right hepatic artery, that will not change the plan, but the length of right hepatic artery after the joint means arise origin of segment 4 artery, that is the deciding factor. Even it arises from left or right, that doesn't matter, but the length which is remaining after the origin of segment 4 artery, that will be deciding factor. As I said, at least 8 7 to 8 millimeter of length they need to anastomose, and that should be extra hepatic. So extra hepatic length of 8 to 9 millimeter they need for the anastomosis.
yeah. Actually, the question was if segment 4 arises from the right hepatic duct. There,
Okay,
then
if
you clarified it. Yeah.
segment 4, as I said, if segment 4 arises from the right hepatic duct, for the right lobe transplant, they don't normally take for that, because with the donor, there will this segment 4 will not be there, because that will come into the resection plane. That is the main thing. And that particular area will be, that duct will get dilated. You will not have the proper biliary drainage of segment 4A and B. So that's why this is a crossover case. And for right lobe graft, it is not taken. If it is a left lateral resection, then it will be taken. Because in left lateral resection, only segment 2 and 3 are the segments which are resected. So that doesn't come with the segment 4.
Yes, thank you, Gayatri. That's all the questions. And we had a phenomenal audience of more than 250 participants today who were enthralled with the knowledge of hepatic segmental evaluation, and also that we could do it even without a major software upgrade. So I'm sure it's going to be helpful with increasing liver transplants and liver lesions across the country. Thanks again, Gayatri, for that wonderful talk, and we hope to host you again on this platform with another new topic on liver transplant imaging. Thank you.
Thank you.
To the
Thank
participants,
you all.
yeah, there are quite a positive comments in the chat box. Do go through them also when you have time.
Yeah, yeah. And if anybody wants to like learn this segmental anatomy and not anatomy, how we do, you are I means you are free to come to Gleneagles Hospital. I'm always there. So I work there.
Yeah, sure. And it's one of the major liver transplant centers in Bombay.
Yeah, we
Uh,
have done almost in last year we have done 80 transplants.
yeah, that's
So that way we do the work. So basic actually, if you see on the console, that will be more useful, that I can do.
yeah. Thank you so much, everyone, and hope to see you again on Saturday with another interesting topic.
Thank you all.